Good morning, everybody. I'd like to welcome you and thank you for joining us today. And thank you to everyone who submitted a question. So we really appreciated those questions beforehand. We have the list of questions and we'll have the panelists go through those questions today in our 45 minutes that we have. However, in the event that the panel can't answer all the questions, the comms team will develop a document to provide out to everybody, and we'll share it next week. So although your question may not get answered or answered today, we will make sure that we get that information out to you as soon as possible. So I believe there's a presentation that's going to come up just shortly. Maybe not. Okay, so before we begin, I just want to remind everybody about, so maybe I can't see the presentation. So sorry, I see people's faces and not a presentation, but others can see it. So if you can just please keep yourself muted. The questions can be put through the panel on the chat feature if you haven't asked one before. We'll be monitoring the chat portion of the meeting, and we will just make sure that if any questions come through, this is about the vaccine itself. It's not about the vaccine policy. So our panel is not here to discuss the vaccine policy itself, but it is about the vaccine and how effective it is and how safe it is to take. And so these are our experts for that sort of information. So we'll be answering questions about the vaccine. So I guess one of the first things I do want to acknowledge is that the last 19 months hasn't been easy, and it's been a lot of work for everybody. And it's been an unprecedented time in the hospital, and it's completely changed the way that we work and how we provide care. And it's been stressful and exhausting for everybody, and I know many of you on this call today. So we are fortunate to be able to hear from our group of experts today, and the individuals here right in our hospitals who know about vaccine significantly more than I do. And I hope you're able to take this time to ask questions about the vaccine, how safe it is, and in particular for people who have particular concerns about their individual circumstances. So you can put them in chat. I don't believe that everybody can see your question. It will come to our communications group. So, and they'll be able to answer them for us. So I would like to introduce the panel. So we have Dr. William Ciccotelli, who is our Medical Director of Infection Prevention and Control Disease at both Grand River Hospital and St. Mary's General Hospital. We have Dr. Theresa, who's infectious diseases at Grand River and St. Mary's General Hospital. Dr. Peter Potts, who's our Joint Chief of Staff for Grand River Hospital and St. Mary's Hospital. And Dr. Todd Walters, who's our Occupational Health and Safety Physician at Grand River Hospital. So we have a number of questions that have been submitted before, like I said, and I will go through those and then I'll ask a panel member to respond to that question. So the first question is, I'm pregnant and I feel like getting the vaccine could put me or my baby at risk. I don't feel it's safe to get the vaccine until my second trimester. Is it safe to have the vaccine while I'm breastfeeding? Why are women seeing changes in their monthly menstrual cycles after the vaccine? So I'm going to ask Peter to respond to that question.
Thanks, Jennifer. Jennifer, can you hear me okay?
I can hear you just fine.
Thanks. So just many folks are probably already aware, but I'll just let folks know that in addition to being the Joint Chief of Staff for St. Mary's and Grand River Hospital, my practice has been in obstetrics for my whole career prior to this. So I kind of have the window on a lot of our issues around vaccine, but also the obstetrical world. So Jennifer, in trying to answer this question, obviously it's a big question. It's a broad reaching question, and it's a question that's very germane for many people on the call today. I thought I might start by looking at the person who's planning to get pregnant, and then looking at the woman who finds themselves pregnant and is considering the vaccine, because I think we need to look at both of those in order to answer this question in a fulsome manner. So in planning to get pregnant, I would say that one of the most important things to consider would be vaccination against COVID-19 in preparation for pregnancy. And the reason I would say that is that we know that if you contract COVID-19 during your pregnancy, the vast majority of cases will be mild. But if you are pregnant, there's a slightly increased risk that you'll experience severe disease and an increased risk of being admitted to the ICU, an increased risk of cesarean section, an increased risk of your baby being unusually small because of the disease. So for those women who are contemplating pregnancy, I myself and other experts would agree that you should be vaccinated prior to pregnancy ideally. And if you're undergoing infertility treatments, the question arises, well, is there a problem undergoing infertility treatment and the COVID vaccine? And I can very surely say that that isn't the case, that you can undergo infertility treatment successfully, and there's no effect on male fertility or female fertility, from the vaccine. The only caveat with that is that if you are undergoing an infertility procedure, experts tell us not to be vaccinated in close proximity to the actual procedure. So if you're undergoing IVF, for example, you would create a window around the IVF procedure where you wouldn't be vaccinated. And there's general agreement on that you'd create a window. But what the experts reassure us about is that it certainly won't inhibit your ability to conceive or carry a pregnancy. The question about vaccine and menstrual irregularities has come up. We did have a look at that as a group, and there's currently no evidence that COVID vaccination can affect menstrual cycles in any demonstrable way. And there are a number of reasons, as most people are aware, why menstrual cycles can vary from month to month, but there's no evidence at all that vaccination has a significant effect on menstruation. So in conclusion, in the lead up to pregnancy, I would say vaccination against COVID, like vaccination against influenza and Tdap, is an important preparation for pregnancy and would be recommended. And for those on the call who are undergoing infertility treatment, they can certainly do the two together. They would just create a window around the infertility procedures and their COVID vaccine. So the second part of the question then is that group of people who finds themselves pregnant and being encouraged to vaccinate. All our evidence to date actually comes from registries of patients who have had vaccination in pregnancy. Pregnant patients were purposefully excluded from the large trials around vaccine safety for obvious reasons. But since those trials have been completed, large registries have been established in Canada and the United States and Israel, among others, that look at women who received vaccination pregnancy and their pregnancy outcome. And those registries have uniformly shown that there's really no effect of the vaccination on the pregnancy itself. In other words, vaccination will not harm the pregnancy. And the registries now are quite large. They number in the thousands of women who have been vaccinated during pregnancy. So we have more and more evidence every day that this is safe and that it's effective in pregnancy. And against that, again, I'll say that the reason for vaccination in pregnancy comes from the fact that pregnancy is an immune compromised state. And if you do if you have the misfortune of contracting COVID during pregnancy, you are at slightly increased risk of becoming quite sick. So that's really the rationale for encouraging folks to get vaccination during pregnancy. The other thing that we've noted is that the vaccination during pregnancy protects the neonate. So that if we look at the cord bloods of newborns, there's abundant evidence of anti-COVID antibodies in the cord bloods. So we know that the neonate is protected in the newborn period. So overall, just to hit the highlights once again, for those contemplating pregnancy, we would strongly suggest you're vaccinated prior to pregnancy. If you're undergoing infertility treatments, there's nothing about the COVID vaccine that'll affect your ability to conceive, either as a male or a female. And then if you are pregnant, we feel the vaccine is safe effective and actually a very important part of pregnancy. So happy to elaborate on that if there's any elaboration needed.
I did see a few questions come in through the chat. And so I'm not sure if someone from communications is monitoring those to be able to ask them. I did see that what came up was where the sources are, where we're getting our sources of information. So we certainly can provide those sources in our further communications when we send the information out with the questions that maybe we're not able to get to.
We are collecting that, Jennifer, and we will follow up with an FAQ and provide evidence as well.
Okay. All right. So Theresa, you put your hand up?
Yeah, if I could just add to what Dr. Potts has said. I know that the menstrual cycle changes that have been noted anecdotally, you know, that's been widely shared on a number of, you know, in the media or social media and so forth. So it is reassuring that so far the data doesn't show a clear association. But it, you know, even in reports that have been noted, the changes are transient, tend to be returned to normal within the next cycle or two. And it's important to note that this is not the first time this has been seen with vaccines. For example, it's been observed for other much older, well-studied vaccines like influenza and HPV vaccines, which have, again, you know, anecdotally or, you know, observationally shown to temporarily affect menstrual cycles, but follow-up studies with those vaccines have shown no effect on fertility. So I feel it's reassuring just from our, you know, our previous knowledge in other areas of vaccinology that this is not a completely new phenomenon. And then one other thing, just more, not only as an expert, but also as someone who has been pregnant 3 times and breastfed 3 children, you know, not during this pandemic, but I understand how difficult it can be and stressful it can be to be pregnant and to feel, you know, responsible for what your choices do. And so as someone who, you know, decides how much coffee I drink during pregnancy or whether I can eat sushi. So I understand that the decision to take a vaccine in pregnancy might be difficult, but it's important to discuss this with your healthcare provider, your obstetrical care provider, and share those concerns and have an open discussion.
So there was just a question that popped up about breastfeeding. And so I'm not sure if anyone is able to speak about breastfeeding with when you have the vaccine or have had the vaccine.
I can start, Jennifer, and then maybe Theresa or Bill will want to add. The consensus is that the vaccine is safe during breastfeeding, that there's no adverse effect on breast milk production from the vaccine. So the vaccination during breastfeeding would be equivalent to vaccination during pregnancy, felt to be completely safe.
Okay, thank you.
Yeah, I think one of the common themes we'll have during this discussion as we go into some of the other questions too is about causation and correlation with rare events. And you know, some of the reports that come out are getting the appropriate attention, and like Dr. Potts has cited and will be provided really good references from Public Health Ontario that are actively looking at all of these questions that come out to give the best answers. But we have to be careful about, with rare events, falsely linking vaccination to negative outcomes without considering all of the other possibilities in one's lives or other things that occur with pregnancy or with breastfeeding that could also explain that. And we also always have to counterbalance that with what will COVID itself do to all of these similar processes? Because what we've seen historically with influenza is all of the rare side effects of the vaccines from influenza do occur, but it tends to be worse or more likely if you got the natural infection itself. So when we're dealing with a pandemic where we really do fear that with Delta strain, we're all going to be exposed at some point, it's trying to kind of balance those frequencies out.
Yeah, thanks. Thanks, Bill. So I know that there's lots of inquiries around the pregnancy and breastfeeding. So I appreciate the feedback on that. I think we'll move on to the next question just because we do have a number of questions and I want to make sure that we do get to a number of the topics. So the next question was, my general health is pretty poor and I'm afraid of the potential side effects of the vaccine. So I wonder, Dr. Liu, can you speak to that?
Sure. So, you know, reassuringly, we've seen that most of the commonest side effects of the vaccine are mild and short-lived, and they're very similar to side effects of other common vaccines, like a sore arm, you know, aches and pains for a day or so. And this is, you know, completely expected because you're stimulating an immune response. Although the mRNA vaccines are relatively new, the technology itself has been developed and studied over decades for potential use in other areas like cancer therapeutics. We are accumulating a great deal of reassuring data, both globally and more locally, that the vaccines are very safe with very low rates of adverse events. So in the province of Ontario and well, most other jurisdictions as well, there is provincial surveillance data. And so every public health unit is collecting what's called adverse events following immunization, or AEFIs. And to be reported as an AEFI, it can be any unwanted or unexpected health effect that happens temporarily after someone gets a vaccine. But to be reported, you don't need to have any proof of causality. It just is a temporal association. And that's to cast a net wide to collect data to make sure we're not missing anything. And so they're looking at all these AEFI reports, looking for any potential signal. And I think there's been about over 21 million doses of vaccine given in Ontario. And for that 21 million doses, there's been about 13,000 AEFI reports. So that's about 61 per 100,000 doses, or 0.06%, which is very low. And because these reports don't imply causality, we don't even know for sure that these reports are all from the vaccine itself, right? So I do feel that it's very reassuring what we've seen both in Ontario and worldwide, that these vaccines are safe. Yes, there will be some serious side effects in a very small minority. Of these 13,000 AEFI reports, 95% were non-serious and only about 5% were considered serious. So I do think it's very reassuring data.
Okay, thank you. So the next question is, I feel like there's insufficient long-term data regarding vaccine side effects. Is this true? Dr. Ciccotelli, can you answer that for me, please?
Sure. And I think it's really good that this follows what Dr. Liu says, because I think we're going to build on the themes that she's raised, because I think what we really kind of are seeing is probably one of the most studied vaccines ever in modern time. There's not been a situation where we have had to face a pandemic of this caliber ever in any of our generations. And so I think what you're seeing is how modern science is trying to tackle this on the fly, which leads to this very fair question, right? But I think to kind of start with some very basic concepts here is, currently we have a number of vaccines that have been approved through the usual refined scientific processes that we've used for all medications and vaccines in the past. There's not been any change to that. There's not been any new safety systems that have been, not used as we've done in past approvals. If anything, it has garnered more attention. And more attention is always good when you're talking about safety, because it brings more and more voices into the mix to have open discussions about how this will be, especially since it is an mRNA vaccine that we're predominantly using in Ontario and North America. But we do have a huge number of experts who study vaccines for a living, and they are all heavily involved in these decisions. And what we can see is, over time, we actually are accruing quite a bit of long-term data. We currently have 6.3 billion doses administered over about a full calendar year. Since the vaccine left its trial data into widespread circulation. And this has now covered multiple countries and multiple ethnic groups, so a diverse number of individuals. And we've seen, quite honestly, this be a very safe vaccine over time. I won't date myself, but I've learned about mRNA vaccines like 20 some odd years ago to what Dr. Liu has said. So these are not new things. They seem new because we've never talked about them in practical use, but they've been around for quite some time. And as I said, there is a lot of interest in tackling diseases where other vaccines have been very difficult to manufacture or as cancer therapy. But what we are seeing is that over time, and if you look at the provided report that will be included from the adverse events reporting, you can see that over a calendar year, we're not accruing a higher frequency of adverse events. You know, the events are stable over time and space, that the proportions are stable, and it really reflects that as we monitor the situation in various pockets and for various key questions and special patient groups, we're not seeing big changes. But what I would also say that as we do study this, and I think it's really great that we're having these conversations about what surveillance systems are out there, because it provides a lot of reassurance and it provides really good numbers to have a good informed, you know, consent discussion around these things. We're seeing people pivot the right way in terms of reacting to safety signals that others are seeing. And once there's enough confidence that the signal exists, even if it's a small signal, it has affected our vaccine, you know, rollouts or our vaccine policies in order to minimize safety concerns. And I think this was clearly highlighted with the AstraZeneca vaccine around, you know, that unusual low platelet syndrome that people were getting. And very recently, it's around key age groups getting Moderna and the myocarditis. So we're using this data to best inform and to always keep vaccine safety foremost in mind, knowing that at the end of the day, a lot of these issues are very, very low risk. And as I said, there's lots of data from natural infections that these events do occur, and they occur at a much higher frequency with the natural infection. So in some respects, the long-term safety within the vaccine world, we've done more than our due diligence at this point, but it's something that we are continuing to monitor, because there is a lot of focus and emphasis placed on these vaccines, and we are and will change policy around which ones we use as we get safety signals through any of the other ones.
So, Bill, there was a comment that came up regarding how safe the vaccine is, and indicating that the trials aren't over till 2023. My understanding is this vaccine now is fully approved, right? Is correct?
So yeah, so there's a number of vaccines that are still being studied. Like I think there's a huge number of companies that are still in the market of doing their studies. And within each of the ones that are fully FDA approved, they are still studying other age groups or special populations to widen or to submit data for possible full approval. So like by no means is the study of these vaccines over. I think a lot of them, though, of the major ones are in what we call the post phase 3 situation, which is they're out for use. There's monitoring that goes on as part of any routine approval process for a period of time. But for some of the newer vaccines, yeah, some of them may still be in their early clinical trials, which really kind of speaks to the fact of we have very good data around the rare side effects with the current approved vaccines by the FDA and Health Canada. We don't know what the other ones will. They haven't gone through their testing grounds. They've not passed through all of the system checks. So, you know, we have something that we have a very well-defined side effect profile for versus ones that we don't know what they will do or how effective they will be in that risk-benefit trade-off.
Thanks, Bill. So I'm just going to jump around a little bit based on some of the chat that is going on. So I wondered, could you follow up a little bit around our question 10 at this point? Are vaccinated individuals less likely to transmit COVID? What is the transmission rate difference between vaccinated and unvaccinated people?
So this is another great question. And I would say the one thing that I would introduce into this discussion at a very early phase is we are learning as we go, because the variants have shifted the conversation slightly. And as data comes out, we always have to appraise it within the concept of where Delta was, where Alpha was as they were doing the studies. but kind of in the Delta era and within what we know within Ontario's, summaries of some of these things, we do believe that there is less transmission, and it would come about through a couple of different measures. So first and foremost, if you are fully vaccinated, you tend to be more mildly or more asymptomatic. And that's important because you're a less efficient spreader of virus. You're not coughing, you're not sneezing, you're not projecting respiratory secretions and droplets into the environment in the way that if you were unvaccinated or had a severe set of symptoms. So that makes you an inefficient spreader of snot and sneezes and all of the stuff that comes with being sick, and therefore also less likely to take that and contaminate the objects around you, which is important when you're talking about preventing transmission. If you look at it from a microbiological virus lens, what we see is people have very quick viral loads that rise and then fall rapidly compared to those that are naturally infected or not vaccinated. So again, we know that there is probably an association between how much virus you carry in your respiratory secretions and how efficiently you transmit. So if you're fully vaccinated, what it appears to be is that you have a very short window of being able to transmit, if at all. And we know that the viral load situation is not a perfect measure of it, but if you took even that at its face value, you have a much shorter window of being actually contagious. And then we start to move into some of the studies that they look at, well, let's do some situational, components, which is, I'm a vaccinated member of a house, a family. I'm a family of 4. I'm fully vaccinated, but I get COVID. What is my chance of infecting my household members if I'm fully vaccinated versus the same scenario if I'm unvaccinated? And it's about a 50% reduction. And I think that doesn't sound like a lot, but remember that the worst case scenario for transmission is within a household. So if we can show a 50% reduction in household transmission, where there's the most interaction, the closest spaces, the most intimate contacts, the most normal behavior in life without mask and social distancing, it is immeasurably beneficial than in the random community interactions that we would have, where we're doing all of the other really, advantageous public health maneuvers. Over time, we're going to see how Delta changes that. We'll get better numbers, but currently right now, we do know that there is definitely a reduction in transmission if you're fully vaccinated compared to those that are not.
Okay, thank you, Bill. We're gonna have to move on. I know it's a very interesting subject, and so it's great to have these experts around. So this is an important question, though, so because I imagine there's some sensitivities around this as well. I'm a recent transplant recipient. Is the vaccine safe for me or other medically complicated individuals? And so, Dr. Wu, can you speak to that, please? Thank you.
So the vaccines are safe for transplant recipients and other people who are medically complex or have other immunocompromising conditions. So although transplant patients were not included in the initial clinical trials, we do now have extensive post-marketing surveillance data showing that the rates of adverse events in these patient groups are similar to in the general population. So the vaccines are thought to be safe. And not only are they safe, they're actually strongly encouraged in this patient group, because there is data suggesting that the vaccines may not stimulate as much of an immune response in these patients after 2 doses. And so that's why now there's further recommendations that for transplant recipients and other certain immunocompromised groups, there's actually recommendations to get a 3rd dose to help boost their antibody levels and improve the response to vaccination.
And so maybe I'll follow up, and I don't know, Bill or Theresa, if you're going to answer this, but it says, will I need a 3rd dose? When will I get it? And I know that there's been, some questions about what's happening in that, especially for healthcare providers and those with immune compromised. So, Bill, do you want to answer that? Do you know?
Sure. I think this is one of these topics that is definitely more in flux than I think we would obviously want a little more certainty. My sense from talking with colleagues is this question is before our vaccine experts in the province and in the country to make this decision. We are clearly seeing a rollout within certain groups and certain age strata, because we do know that there are generally inefficient responders. And this isn't something new with COVID vaccination. This is just vaccination in general, that things happen to one's immune response if you have significant chronic medical health conditions, or you tend to be over the age of 70. And so for these groups, this is where the active interest is, because we're seeing a signal that as time goes on, their ability to acquire COVID is showing some weaknesses, and the ability to protect them from needing hospitalization is showing some weaknesses. And so it seems, based on data from Israel and other Western countries where they're studying this actively, that boosting them is the only thing we have of maybe keeping them well. And so given the safety of the vaccine, that's why that has come about within Canada and within the United States. The healthcare worker thing, I know it's being actively deliberated on. I would not be surprised that that's where the discussion goes. Again, for healthcare workers, not so much about keeping them out of hospital with severe disease, but trying to break transmission or their ability to transmit to colleagues and patients by making sure their antibody levels are the best that they can be.
So to follow up a little bit about antibodies, there's obviously people have contracted COVID over the last 19 months. And so would maybe have natural antibodies to COVID and maybe don't feel that they need a vaccine. So Bill, could you follow up on that?
These ones are all nicely tied together, and I think in this situation we'll have to kind of just lay out a little different view here, because I think we all have to remember, as we started the conversation, that we're very much in pandemic control mode. We're not in control of this pandemic. Not yet. I think we're getting closer than we've been before, but there's still some uncertainties here, and there's still a number of individuals that are not vaccinated or can't respond well, that really kind of jeopardize how we can keep people out of hospital and keep them from dying from the disease. But when we talk about natural infection and recovery from natural infection and the immune response, I would really want to split that into two different thought processes. And it comes back to what I said with the third dose. So one thought process is that you're stimulating one arm of your immune system that does really well at preventing you from getting severe disease and hospitalization, and maybe, issues around, end organ complications or long COVID. That seems to be a very stable and important aspect of either vaccination or natural infection. But where we're really kind of meeting some of the challenges is around that antibody level, and especially around how long does it last and how functional is it. And I think over time, no matter how you've been exposed to COVID, that antibody level does show a drop. And so vaccination and boosting is really all about keeping you from being somebody who could acquire and transmit. And then especially in a healthcare setting where that's really important, because we do deal with a number of individuals who are not really good responders of the vaccine, or for other health conditions can't get the vaccine. And so the natural immunity is only good for so long. We're all going to be boosted one way or another if this proves to be a really important step. And in addition, I think there's some really important things to remember when you hear about data around unvaccinated and vaccinated individuals. And that is that people who are prior infectious or had immunity through prior infections, they're still getting COVID again at a higher rate than those that are vaccinated. They're part of the unvaccinated group. Or in some jurisdictions, I think it was Utah or Kentucky, they've teased them out, and they're still getting COVID at a rate of 2 to 1 compared to vaccinated individuals. So there may be some net difference between how the immune systems work between the two mechanisms.
Thanks. So I guess, and this is for Dr. Walters. We've been through this for 19 months, and we've been using our PPE. So some feel that having the PPE should be well enough to manage COVID in a healthcare environment. Can you speak to a little bit about, is PPE enough?
Thanks, Jennifer. It's a great question. And, you know, initially, when this all started, we scrambled to find PPE, and we used PPE on the most, as sparingly and and yet trying to be as effectively as we could. I think safety in the hospital is really about, you know, accumulating layers of protection. And we look at safety and protecting both the employees and the people we serve in hospital as sort of in different layers of protection. And, you know, I think if we weren't in a pandemic, if we weren't facing something that that really, we were in a regular situation, we would be functioning, as everybody is aware, in a much different way. So we initially used PPE because it was really all we had. And I think now we know and we see and we hear from, you know, the experts around us, and we learn from the scientific study and literature that in fact we can add another control. We can add to the level of safety that we have. I sort of think about it in sort of a practical manner, as, you know, if you go up on a step stool and you stand on the second or third step, you know, you don't wear a safety harness and you're not strapped on and someone else doesn't have to be there. But if you're going up a ladder and you're going up 10 or 12 feet, you want the ladder restrained. You want to be in a safety harness. You want to have fall protection. And we mandate those things in the workplace. And so, yes, PPE is at the start was all we could offer. But I think now we're looking at a different level of safety that's available to us, and to not provide that safety seems frankly less than responsible. You know, one of the things about PPE and is that, you know, and this happens to me, you know, I get out of my car and I'm going to go into to a coffee shop or something, and I get 3 steps away from the car and I realize, you know, I don't have my mask. And I go back to the car and I get my mask and I go in and I get my coffee or whatever else. The beauty of a vaccine, and this happens in the workplace, you know, people are in situations where, you know, they're having their lunch, they get up, they leave, they forgot their mask, they go back, they remember it. The beautiful thing about vaccine is you're never going to forget it. You've gotten it, it's with you, it provides a level of safety that's greater than is available through PPE, and you're never going to have that, you know, oops, I forgot it moment. And so I think maybe I'll stop there, but I think that really, addresses that we're trying to provide as safe an environment as we can. And this is a safer environment than just PPE alone.
Okay, thank you. I wonder if I can just ask you about, what if I'm allergic to one of the vaccine components? Is it still safe for me to be vaccinated? Would it keep me from getting vaccinated?
That's a really good question, and a very pertinent question, at this time. So, true allergy, anaphylactic reaction to ingredients of the vaccine is rare, but it exists. Mm-hmm. And I think we recognize that it exists, and there are specialists amongst us, amongst the community, who are able to help us if we have a true anaphylactic reaction. If we have a prior anaphylactic reaction to any of the specific ingredients, PEG being the number one sort of known and ingredient that causes allergy in people who receive vaccine. So the government of Ontario has an e-consult service. And if your primary care practitioner is unable to provide you with an allergist or immunologist who can assess you for anaphylaxis, if you've had that before, there is an e-consult service which is available and really outstanding and accessible to all. Further, there are special clinics, immunization clinics across the province. In fact, they're federally funded, so they're across the country, which are designed to address, vaccine allergy. And so, true allergy, discuss with your primary care practitioner, get specialist assessment and evaluation, and at that point, they'll be able to determine whether you're safe to be immunized in an environment where it's controlled, or whether you should be receiving, an alternate type of vaccine that doesn't contain PEG.
Yeah, thank you very much. I want to make sure I get to one of the questions that was submitted prior. And so in the media, there's been lots of things said about the vaccine. And so one of the things I would like to have some clarification on is are there aborted fetus cells in the vaccine? And so Dr. Liu, can you speak to that?
Yeah, certainly. So there's no actual cells from aborted fetuses in any of the vaccines. So the viral vector vaccines, so AstraZeneca and Johnson & Johnson, and AstraZeneca, which was available, which we're no longer using widely in Ontario, and Johnson & Johnson was never widely available in Ontario. So those two vaccines were developed using immortalized fetal cell lines, but not actual aborted fetal cells. So the distinction is that fetal cell lines are cells that initially were derived from fetal tissue obtained decades ago that have alterations that allow them to grow and multiply for prolonged periods of time. And so they can be propagated over generations in a lab over decades, so no longer contain any actual fetal tissue. The mRNA vaccines, so Moderna and Pfizer, which are used now, were not grown in fetal cell lines, but fetal cell lines were used in some of the confirmatory testing in the lab with those vaccines. But several religious groups and other organizations have issued statements and guidance about these. So for example, the Vatican and the Canadian Conference of Catholic Bishops have issued clear guidance saying that Roman Catholics in good faith can receive the COVID-19 vaccines to contribute to the common good and protect the health and safety of others around them. So yes, that is a concern, but not only the Catholic Church, but also other prominent religious organizations have made similar statements.
Okay, I think I might have time for one more question, so thank you for that. There's been a question come up that says, I've had chickenpox, so I didn't need the varicella because I had natural immunity. So why would this be different if I had COVID? Dr. Ciccotelli, can you respond to that?
Yeah, I think this is a great one to build off of the natural immunity question. And I think, in very short order, because I know we're running out of time, every virus seems to have a different need of different components of the immune system to lead to protection. And so it's probably not fair to compare one viral infection to another, looking at how much of the antibody response or how much of the cell-mediated response we need in our immune system. So there may be different key components there. And with viruses like chickenpox, they have a very different biology of how they infect the cells and stay latent than, say, respiratory viruses. So it's not, vaccine development and immunity is not a one-size-fits-all situation. And conversely, I think, the message around chickenpox too is, again, with before the development of the vaccine, that's the best we could do, is just try to help manage the infection. But I think even then we saw a lot of very devastating cases of complications from chickenpox in young children that weren't so lucky. And so again, the vaccine was developed to help ensure that they could be immunized and protected against chickenpox without suffering some of the unwanted consequences. And I'm old enough to have seen some of them during pediatric rotations to kind of, really, be thankful that that vaccine exists to help kids not have to suffer through that infection.
Okay, thank you. I think we did have a number of questions come through that may not be able to have been answered today. But when we started, we said if we couldn't get to them all, that we would certainly make sure that we will send them out in the frequently asked questions. And if you have questions that you weren't able to submit on the chat, then you can still do that through the comms team. So at this point, I'd like to thank everyone for attending, and especially